So I welcome everyone here. Today our class is on allergic rhinitis and nasal polyposis. So first our President NEBAOI, Dr. Shubhamoy Chakraborty will introduce our expert, Dr. Neelam Ved, Madam.
Good evening, madam. Thank you very much. Dr. Neelam Ved is a prominent Pune-based ENT surgeon. At present, she is heading the Department of ENT at KEM Hospital, Pune. She is specialized in cochlear implant and she has performed over 750 procedures till date. She is her academic contribution. She is focused on cochlear implantation in pediatric and adult population, with work featured in studies on parental decision making.
Yes.
She has gotten numerous publications in both national and international levels, and her achievement is participated in Comrades Marathon and worked at the Everest Base Camp. He's a seasoned marathoner, completed 100-kilometer endurance run in Rajasthan just in 15 hours 31 minutes. So I welcome Professor Neelam Ved, Madam, and we are honored that she has kindly consented to be the external expert in this webinar. Thank you, Madam. NEBAOI welcome you.
Thank you. Thank you so much.
Thank you, Dr. Chakraborty. Now our speaker, Dr. Diptika Bhattacharjee, will be introduced by our NEBAOI Secretary, Dr. Anjan Bhuya. Dr. Anjan.
Thank you, ma'am. Good evening, everyone. All the NEBAOI members are most of us here in our classroom today. So today's topic will be on allergic rhinitis with nasal polyposis. So it will be a first topic on as we are discussing on pathophysiology and clinical management. So today's lectures will be delivered by Dr. Diptika Bhattacharjee, who is doing her postgraduate degree in Tripura Medical College. She is a third year student. So with her deliberation, maybe it will be very. So we'll have a lot of things to discuss on allergic rhinitis with nasal polyposis. So I welcome Dr. Diptika to deliver her lecture. Thank you.
Good evening, sir. Thank you so much.
Just a minute, Diptika. Yeah. Now in our classroom, today's moderators are Dr. Kripamoy Nath and Dr. Akriba Ahmed. So our chairman, scientific committee, Dr. Hiranya Bora Madam will be introducing them.
Good evening, everyone. Today's moderator, Dr. Kripamoy Nath. Whether he joined or not, I don't know.
He's
but
there, he's there, madam. He's
okay.
there.
Let me introduce Dr. Kripamoy Nath. He is presently working as Associate Professor in the Department of ENT, Silchar Medical College. He has more than 12 publications in national and international journals, and he has several achievements. It is very long to describe all this, but apart from that, apart from ENT, he has distinction in professional diploma course in photography from Chow Academy. So I welcome Dr. Kripamoy Nath to moderate today's session. Our another moderator, Dr. Akriba Ahmed, she is a renowned allergy. She is a practitioner in Apollo Excel Care Hospital, Guwahati, as well as she is the consultant in Dr. Akriba ENT and Allergy Clinic in Guwahati. And her areas of interest is allergy and neuro-otology. I welcome Dr. Akriba Ahmed to moderate today's session. Thank you.
Thank you, madam. So, Dr. Diptika, you can start your presentation and your time is 30 minutes.
Okay, ma'am. Thank you so much, ma'am. Good evening, respected expert madam and moderator madam and sir, and all faculty members of NEBAOI and everyone present here. I'm Dr. Diptika Bhattacharjee, and today I'll be speaking on allergic rhinitis and nasal polyposis, pathophysiology and clinical management. So what is allergic rhinitis? Allergic rhinitis is defined as an IgE-mediated condition of the nose following an exposure of allergen to the lining mucosa of the nose, which is mainly characterized by symptoms like rhinorrhea, sneezing, and nasal obstruction, which may be associated with allergic conjunctivitis and bronchial asthma. It has been seen that around 400 million people worldwide suffers from allergic rhinitis. The incidence in children over the first 5 years has seen to be around 17.2%. Almost 80% of allergic rhinitis symptoms develops before the age of 20 years, and it generally peaks at 20 to 40 years of age before gradually declining. So now coming to the classification of rhinitis, rhinitis can be classified into allergic or non-allergic. These are the various causes of non-allergic rhinitis, but I will not go into detail of it. So coming to the allergic, it is actually classified into seasonal or perennial or intermittent and persistent. The seasonal one is the seasonal allergic rhinitis is the one which generally presents during one particular season, which is mainly caused by pollens, grasses, or weeds. The perennial one is actually the one which is present throughout the year, and main causative factors for the perennial allergic rhinitis are the indoor allergens, the house dust mites, etc. So the allergic rhinitis and its impact on asthma guidelines, the AREA guideline has classified it into intermittent and persistent. So intermittent is the one where the symptoms last for less than 4 days per week, and the persistent one is when it lasts for more than 4 days per week. It also describes the severity, classifies it into the severity of it, where it is converted to divided into mild and moderate or severe. In the mild, actually what happens is that the day-to-day activities, the sleep pattern of the patient is generally not bothered by it. But in moderate to severe, generally there is the day-to-day activities, the sleep patterns, the daily activities becomes bothersome. So the AREA 2016 guideline has introduced one scale, which is a visual analog scale, which is actually a very simple patient-reported tool, which is recommended by the AREA guideline. This is mainly used to assess the symptom severity and guide treatment in allergic rhinitis. It is calibrated from 0 to 10, with 10 being the highest and 0 being the lowest. There are various risk factors which are actually associated with allergic rhinitis. Amongst them, the most common are family history of atopy, patient belonging to higher socioeconomic status, firstborn status, both during pollen season, early introduction of formula, and early use of antibiotics, indoor allergen exposure, or smoking exposure before the age of 6 years. Even presence of allergen-specific IgE. Now I will be describing about the pathophysiology of the allergic rhinitis. So what happens is that it has been actually classified into two parts, the allergic sensitization phase and the symptom generation and the inflammation phase. So what happens is that we have our respiratory epithelium. So when this respiratory epithelium, it comes in contact with the allergens, the various viruses, smokes, they secretes alarmins, the TSLP, the interleukin-25 and the interleukin-33. So this will help, this does what? This will be picked up by the antigen presenting cells, also called the dendritic cells, which converts the antigens to the peptides. Now they will present them to the T helper cells, that is the Th2 cells. Now these Th2 cells actually produces the interleukins. So we have the interleukin-4, interleukin-13, interleukin-5. Now these antigens which will be presented to the B cells. Now what happens is that these interleukins which are already produced by the Th2 cells, the interleukin 4 mainly helps in class switching of the B cell. Now what is class switching of B cell? Class switching is mainly what as a B cell actually usually produces a IgM antibody, but based on the cytokine to which it is exposed, it produces IgG, IgA or IgE. Now, when so in this case, in allergic rhinitis, the IgE is generally produced. The interleukin-5, on the other hand, is also responsible for the growth and promotion of the B cell. So what happens is after this thing has occurred, now the IgE will sit on the mast cells. Here we can see this is they are sitting on the mast cell. This is called the priming sequence. Now again, when the allergen when the patient gets exposed to the same allergen, these mast cells who are already loaded with the IgE, now when the antigen comes, they will react to these IgE antibodies, and that will cause cross-linking. And what will happen? This will cause degranulation of the mast cell. So when degranulation of the mast cell occurs, they releases the inflammatory mediators. Now we have two kinds of inflammatory mediators mainly. We have the preformed mediators, which are mainly the histamine, the heparin, and the newly formed mediators like prostaglandins, the leukotrienes, the platelet aggregating factors. Now, based on the secretion of the mediators, we will have the symptoms like histamine, which is the most potent mediator that causes vasodilatations, the edema of the mucosa, nasal blockages, that is by hyperactivity of the mucosal gland, and it causes rhinorrhea. Now, what happens is that this reaction is also actually can be seen into the acute phase and the late phase. So acute phase generally comes within 5 to 30 minutes, the first initial 5 to 30 minutes, which will be mainly characterized because of this histamine release and prostaglandin release by sneezing, rhinorrhea, vasodilatation. And in the late phase, what happens is that the new modulators, which comes around at 2 to 8 hours, there will be congestions, nasal blockage, more eosinophil recruitment, which will ultimately result into tissue remodeling and inflammation. Now, what is allergic priming? Allergic priming is actually due to repeated allergen exposure. The amount of allergen which will be required for the immediate response, the next time it decreases. For example, now X amount of allergen causing disease at one pace. But what will happen is that if with repeated exposure to the same allergen, very small amount of allergen will require, and the symptoms will also be more in case of that is our immunity becomes primed to that allergen. Now coming to the clinical features. So allergic rhinitis is mostly the most commonly have features like sneezing, frequent intervals of sneezing throughout the day, which will be more during the morning time. There will be watery mucoid nasal discharge, itching of nose, eyes, palate, redness of the eyes. There may be periorbital edema or foreign body sensation or burning sensation of the throat, nasal obstructions. Now, here are various few of the signs which are most commonly seen in case of allergic rhinitis. In the first image, we can see that the allergic salute. What is allergic salute and why does it occur mainly? It mainly occurs because when patient will have continuous rhinorrhea, the patient will have a tendency to rub his nose with his palm in the upward direction. That results in the formation of this line, which is called the allergic salute. Here we can see the Denny-Morgan lines. This is also because of the repeated swelling. What will happen? There will be permanent crease formation will be there. The skin thickening will be there. And also there will be loss of skin elasticity, which will result into this Denny-Morgan lines. Here we can see the allergic shiners. Allergic shiners mainly occurs because of the venous congestions. The cobblestone appearance of the conjunctiva, it mainly occurs because of the glandular hyperplasia. In the eyes, it is seen. Because of repeated tube blockage, it can also result in serous media. Here in this image, we can see the granular pharyngitis because of the hypertrophy of the lymphoid tissues. Now coming to the diseases which might be associated with allergic rhinitis. The most common diseases are like nasal polyposis, bronchial asthma, chronic rhinosinusitis. It can be with nasal polyp or without nasal polyp. Now it has been seen that why it is important that primary chronic rhinosinusitis actually, it can be manifested by actually 3 types of inflammation, which is type 1, type 2 and type 3. Now coming to the type 2 one, the type 2 actually is the most common form. It has been seen that around 85% of chronic rhinosinusitis with nasal polyposis patient has type 2 kind of inflammation. So this endotype, knowing this endotype is very important in order to differentiate it from the other types. Now, what is a nasal polyp? So nasal polyp is actually a pedunculated mass projecting from the mucosal surface, usually from the chronic inflammation, edema and mucosal proliferations. They are mainly of 2 types. We have the antroquinal polyp and the ethmoidal polyp. Here we can see ethmoidal polyps. So the ethmoidal polyps are generally bilateral. Here we can see in this CT scan, coronal section CT scan also, that bilateral ethmoidal polyp. The ethmoidal polyps are actually, as I have said, it is generally seen in elderly patients. Then the main reason is the allergy. And also this will mainly cause because of the, this will be pale, bluish, and glistening structure of the polyp can be seen. Now coming to the antroquinal polyps. So antroquinal polyps are mostly seen in case of children. They mainly arises from the maxillary sinus when it comes out to the maxillary ostium or the accessory ostium. And this is general, here we can see one image which is showing a pale, one singular polyp. So this polyp is generally one, singular in number, and it is unilateral. It shows an unilateral presentation, and it is more common seen in children. Now I will be coming to the pathophysiology of the nasal polyp. Like I have said before, that nasal polyposis mainly occurs because of type 2 type of inflammation. So what happens is that, again, when our nasal mucosa, it gets exposed to the respiratory epithelium, gets exposed to this, we will have this TSLP, interleukin 33, 25, these alarmins will secrete. Again, they will trigger the type 2 inflammatory cascade. So when the type 2 inflammatory cascade will be secreted, our interleukin 4, 5, and 13 will be secreted. So what happens is that this interleukin 4, they will cause class switching and this piece IgE formation, and all these things will happen, that inflammation. Now the main common is the interleukin 13. What it will do is that this interleukin 13 is actually, it has a thing of, it increases the matrix deposition. It increases the matrix deposition and the goblet cell hyperplasia, and causes mucus secretion, increasing the amount of the mucus secretions. So what happens? So repeated exposure, repeated inflammatory cells in the submucosa. Here we can see that repeated inflammatory cells in the submucosa, it enhances the secretions of the mucus. And as a result, there will be scarring in the epithelium submucosal layer. And this scarring will ultimately have a puckering. This will cause puckering of the nasal epithelium, and there will be a bulging of the submucosa, and also the fibrin depositions along with it results in the proliferation of the nasal polyp. Now, there are various risk factors which are associated with nasal polyposis. We have allergic rhinitis, Sumter's triad, which is composed of aspirin intolerance, bronchial asthma, ethmoidal polyp, cystic fibrosis because of thick mucus production in case of cystic fibrosis. It can have allergic fungal sinusitis, Carter-Jenner syndromes, or Young syndromes. This might be the risk factors for nasal polyposis. Now, the various clinical features of patients presenting to us with nasal polyp. They can have nasal stuffiness or obstruction, partial or total anosmia, headache. They can be sneezing or purulent nasal discharge if there is associated infections. They can have post-nasal drip. Now I'll be discussing about the various scoring system. So the Lund-Kennedy endoscopic scoring system actually scores it from 0 to 12. More the score, higher is the severity. So this actually evaluates it on the few parameters, which is polyps, edema, discharge, scarring, and crusting. 0 for, in case of polyps, if there is no polyp, it will be 0. If one polyp in middle meatus, it will be 1. If 2 polyps beyond the middle meatus, it is 2. And based on it, it is scored. We have one more scoring system, which is the Lund-Mackey city scoring system, which is actually grading this. 0, there will be no mucosal thickening based on the sinuses involved. 1, if there is partial opacification. 2, if there is total opacification. They are generally given scoring of 1, 0, 1, or 2. But in case of osteometal complex, it will be either 0 or 2. There is no 1 in it. Now we have one more grading system, which is a Meltzer polyp grading system. Here we can see that what happens is that it is depend if the polyp does not extending. 0 is if there is no polypoidal tissue. If the polyp is not extending beyond the middle turbinate edge, then it is 1. When it is extending beyond the superior margin, it is the inferior turbinate. It does the 3 is when it does not extend beyond the middle of the inferior turbinate. 4 is it is not touching the floor of the nose, and 5 is when it touches the floor of the nose. Okay, now coming to the diagnosis. So when a patient presents to us with the symptoms, signs and symptoms after examining, we will, first of all, we will take detailed history of the patient, and after that we can go for the various workup, where we can go for anterior rhinoscopy. Here we can see that in anterior rhinoscopy, here in the left nostril, we can see a pale blue glistening pedunculated mass, which is seen on anterior rhinoscopy. If we see such a mass, we can go for nasal probing test, because in case of nasal polyposis, we can actually rotate the probe through or in all the sides, and it is actually, polyps are actually insensitive to pain, and they are generally bloodless. Then we can go for diagnostic nasal endoscopy. Here we can see that in case of diagnostic nasal endoscopy, we can find the polypoidal tissues. Allergic mucins can also be seen. We can go for CT scan of the nose and paradisal sinuses. Then we can go for complete blood count, ESR, absolute eosinophil count, skin prick test, which is generally the gold standard for this, the Fadiatop test for serum-specific IgE, the RAST, and the nasal provocation or challenge test. Now I'll be discussing about the skin prick test in short. So the skin prick test is actually when we are pricking the skin with the needle. So what happens is that we will put it, we have a control. We'll have a control. So one negative control we will have with saline, and we have one histamine control. After that, we will inject it. So we will inject it. The allergen solution will be injected into the skin, and we will see the response. Generally, it is seen after 10 to 15 minutes, how we will see if there is wheal or if there is flaring. So generally, more than 3 millimeter is then in comparison with the control is suggestive of positive skin prick test. Now I'll be discussing about the management part. So we have the avoidance of allergen. So first thing is the avoidance of allergen. So and patient education. We have to educate the patient about regarding the avoidance of allergen. Like during the pollen season, how they have to avoid, and they have to clean their home clean. Their houses should not have the molds in those cases. The pharmacotherapy and immunotherapy and surgical management. So the pharmacotherapy are the most various common drugs which are used are the antihistaminics. Routinely, we use as a second generation antihistaminics, which generally composed of cetirizine, levocetirizine, bilastine, loratadine, fexofenadine, because of the advantages of it. We have the nasal decongestants like oxymetazoline, xylometazoline. But one thing has to be taken care of, that they should not be given for more than 7 days, because it can can cause rhinitis medicamentosa. We can use the mast cell stabilizers. We can use the leukotriene receptor antagonists like montelukast, zafirlukast, and also the anticholinergics like ipratropium bromide nasal spray. Intranasal corticosteroids like fluticasone, budesonide, mometasone actually forms the mainstay of the treatment in case of allergic rhinitis and nasal polyposis. Systemic drugs, if not controlled, can also be added, oral steroids like prednisolone, deflazacort. So coming to the area guidelines for the management. So what is it? So this is actually when it's a mild or intermittent disease, we are using the oral or topical nasal decongestants can be used, should not be for less than 7 to 10 days. We will use the oral non-sedative H1 blockers, as I have mentioned. But when it comes to moderate to severe, there we can start using the intranasal steroid, the local chromones. And also the immunotherapy can also be started when it becomes severe or persistent, and if it is not being controlled. I'll come about immunotherapy in the next few slides. Now what happens? So as I have mentioned before, the visual analog scaling. So this is very important in treating the patients of allergic rhinitis according to area guideline. So what happens is that when the VAS is less than 5, VAS score is less than 5, we will first start a patient on anti-H1 antihistaminics. After that, if the symptoms are actually intermittent, or if the symptoms are intermittent or persistent, and if there is exposure of allergen, we will reassess the VAS every day up to day 3. So when the VAS goes less than 5, in that case, if the patient is still symptomatic, we can continue the treatment. If no, we can stop the treatment. But if the patient's VAS still stays equals to or more than equals to 5, then we have to start the patient on intranasal corticosteroids. And then we have to reassess the VAS up to day 7 every day. Again, after reassessing, if the VAS still remains more than equals to 5, then we have to step up. That is, we have to consider for immunotherapy. Similarly, if the patients are untreated, in case of if it is less than 5, in that case, we will start less than 5 or be it more than 5. We can initiate the treatment with antihistaminics, and we can use intranasal corticosteroids. But even after reassessing it for every day for 3 days, if it still stays less than 5, then we will continue the treatment. If no symptoms, we will consider for a step down. If it is more than, we will go for step up, and we can actually start for immunotherapy. So what is actually immunotherapy? So immunotherapy is actually nothing but this induces the immune tolerance to allergen. So this is just that after gradually increasing the quantities of allergen to extract to an allergic subject, we will eradicate the symptoms by subsequent exposure of the causative allergen. This has shown to be high success rate of 80 to 90% with a course of 3 to 5 years. It should be continued. We will go now to one of the very important and newly topic, that is the biologics, role of biologics. So what are biologics? Biologics are actually advanced targeted therapies which are derived mainly from protein cells and genes. They work by inhibiting the type 2 immune effectors, interleukin 4, 13, 5, and the EPOS 2020 guidelines has also advised the use of biologics in the treatment of nasal polyposis. So how do you choose a biologics? Based on the local availability, types of the comorbidities associated, or the level of the blood biomarkers and cost. So for choosing indications for the biological treatment, out of all these, 3 criteria has to be fulfilled. What are those? If there is tissue eosinophil count is more, there is evidence of type 2 inflammation. If there is need of systemic corticosteroids for more than 2 courses per year, significantly impaired quality of life, if significant loss of smell and diagnosis of comorbid asthma. So the most commonly used biologics are the anti-IgE biologics, which is routinely used as a omalizumab, which is given actually according to body weight and serum IgE level. The dose is generally 75 to 600 milligram subcutaneously every 2 to 4 weeks. The interleukin-4 receptor blocker, dupilumab, is also actually an anti-IL-3 biologic. This is given at a dose of 600 milligram of loading dose that's followed by 300 milligrams subcutaneously every 2 weeks. And the interleukin-5 biologic is a mepolizumab, which is being given at a dose of 100 milligrams subcutaneously every 4 weeks. Now, how do we understand that whether our biologic is actually working or not? So this is also evaluated based on this criteria. If there is reduced nasal polyp size, reduced need for systemic corticosteroids, improves quality of life, improves sense of smell, and reduce impact. So we will give them these responses. Now we will evaluate these patients after 16 weeks. So if we are seeing after 16 weeks there is no response, we will stop it. And otherwise we will continue it. Then again we will evaluate the patient after 1 year. If after 1 year, again if there is no response, we can stop the use biologics. Now I will be talking a little bit about the recent advances, which is the Sinuva and the Dupinext. Actually, these are very recent advances. These are the devices which are main commonly used. So this is a sinus implant, which is a prescription steroid releasing implant, which is generally used in chronic rhinosinusitis with nasal polyposis patient, should be given after the age only in adult patients after the age of 18 years. This releases mometasone, and they are placed in the ethmoid sinus. And we have Dupinext, which is actually a dupilumab only. Now coming to the surgical management for AR. Actually, surgery is usually considered only when medical therapies like nasal steroids or biologics fail, or in case of, mainly in that case only. If there is, we can go for inferior turbinate reduction or posterior nasal neurectomy, which is generally not performed much. Now coming to the surgical management for nasal polyposis, previously many other surgeries were there, but nowadays the most commonly surgeries which we do are the endoscopic sinus surgery or the endoscopic assisted polypectomy is only done when small polyps which recurs, which can be removed. Now coming to the endoscopic sinus surgery, this actually it improves the sinus ventilation and drainage as well as by removing the polyps. The newer advanced surgeries are the reboot surgery and the computer-assisted sinus surgery. The post-operative care is very, very important. We should go for nasal douching and intranasal and systemic corticosteroids to stop recurring of the polyps. The long-term management includes regular follow-up, managing the underlying condition of the patient if they are having bronchial asthma or atopic dermatitis, aspirin desensitization in the patients who are sensitized to aspirin, and lifestyle modifications like avoidance of allergens mainly. My take-home message is for today's class is that allergic rhinitis and nasal polyposis are actually chronic inflammatory airway diseases. One airway, one disease. We have to always assess for asthma, and intranasal corticosteroids forms the mainstay of the treatment. In case of allergic rhinitis and nasal polyposis, medical therapy comes first, and surgery is an adjunct. Surgery is not the cure of it. So there are two main things, which is allergen avoidance and immunotherapy, which mainly acts in the disease-modifying treatment for allergic rhinitis. The AREA 2024-2025 guideline has said that intranasal antihistaminics and intranasal corticosteroids, a combination of these two, actually leads to significant improvement in symptoms. Thank you.
Thank you, Dr. Deepshika Bhattacharjee. Very beautiful presentation. May I request Neelam Vaid ma'am to give her expert comments?
Wow, that was an amazing presentation. I mean, in 30 minutes to cover such vast topics, hats off to you, Deepshika. It was really nice. I must say that you kind of stimulated a lot of discussion. I can see a lot of questions even coming up in the chat. I think when I go through your presentation, there are a couple of things for me that stood out is Allergic rhinitis and nasal polyposis actually are very, very different. And for us, this thought process that we always think that, they're both the same, they are not. They're really very, very different. I do agree with you that allergic rhinitis, yes, you said it's, IG mediated. The one thing that we have to really remember is that it is genetic. And that's something that we need to keep harping about when parents come, patients come. They always expect from us a cure. And I think the one thing that you and I have to realize that when a patient comes to us with allergy, it's basically a combination of genetics and environment. There is something genetically that has caused a damage in that person's epithelium. And the whole thing starts from an epithelial barrier problem. And through that enters the antigen. So that part is genetic, which we can't really control. And then, of course, the environment kind of contributes to it, and you get these various symptoms. When we talk about allergic rhinitis, we have to remember something called the atopic march. When we say people get it as children, I think what you really need to look at is if you look at the history, you'll realize that most of it will start with this child having some GI symptoms. He will then progress to maybe having some skin symptoms. And the allergic rhinitis actually comes in much, much later. It does not really come in very early. So allergic rhinitis, if you really see, is definitely something that comes in much later in a person's life. It does decrease with age, and one of us have never thought, you have patients who the parent will come and say, I had a lot of allergies as a child, but by the time I was about 30, my allergies disappeared. And they will, say it's because they maybe took Ayurvedic or, the allopathy worked. It's got nothing to do with that. What happens is that as we age, the production of IgE in our body decreases. So a lot of us, when we grow old, we do not get those many symptoms of allergic rhinitis as maybe we used to get when we were kids. So that's something that, one should remember and counsel them that, yes, you won't outgrow it. It's just that the IgE production will kind of come down. Again, when we look at children, remember one thing that when you look at counseling the parents and you're talking about indoor allergens, outdoor allergens, most of these children will get sensitized to indoor allergens as early as 1 year of age. I'm not talking about presenting with clinical symptoms. I'm talking about sensitization. That means the child is now getting to a point where they will in future, when exposed to that particular allergen, present with symptoms. So that's called sensitization. And to outdoor allergens, it only develops as late as maybe the child is about 3 years. Now, the other thing that one must remember, something called a hygiene hypothesis. You mentioned it, that the incidence of allergies is more in the higher socioeconomic group. And when you think about it, there is a reason for this. There is something called the hygiene hypothesis, which is something that we see today more and more. We see it more in small nuclear families, is the fact that when we are exposed to more microbia as children, we develop more of what's called the Th1 pathway. Now, the Th1 pathway is the one that is anti-allergic, the one that protects us from allergens. So I always tell the parents of today, the more you're going to protect your kids from infections, the more you're going to, use hand sanitizers, don't let these children play in mud, etc. We are actually not letting the Th1 pathway develop, which is the most important from them developing an innate immunity towards allergies. Your nasal polyps, I think one must remember that there has to be a classification. The old classification of saying antroconal, ethmoidal, that's out now. I mean, when we talk about nasal polyps today, we will classify them into basically three. You will say they are localized, they are diffuse, and they're systemic. That's how you will now classify nasal polyps. Localized means it could be because of a neoplasm, it could be because of a local inflammation. Diffuse is the one that we see more commonly, the one that's associated with allergies. And systemic is an underlying systemic disease. It could be something like cystic fibrosis. It could be something like your eosinophilic granulomatous polyangiitis, or what was previously called Crook-Strauss disease. So this is the way you will classify nasal polyps by and large. So the old classification of antroconal, ethmoidal, I think is no longer really used. What's more important today is that when we look at classifications, we moved on from clinical, which was, the localized, the diffuse, the systemic. We then moved on to what was called a tissue-based pathology, where we looked at, is this polyp got more of eosinophils? Does it have more of neutrophils? Does it have more of plasma cells? And that was the next stage, where we moved into what was called endotyping. But now we've even gone one step further. So now when you've gone into endotyping, which is called T1, T2, T3, and that's now based more on the interleukins. So this is, of course, something which is a little extensive when you come to a discussion on allergies, but this is extremely important today. As a student, you should know that today when you discuss with your pathologist, to just report a polyp and say, oh, this is signs of chronic rhinosinusitis is no longer enough. There's actually a classification where they've got to give you the cell, they've got to give you the basement cell membrane, and it's there. If you discuss with your pathologist, they'll start giving you those reports. And that makes a big difference. Because if I have a tissue that's reported to me as predominantly neutrophils, I have basement membrane thickening happening, my treatment is different. My prognosis to this patient is completely different. So I urge you guys to talk to your pathologist to now change the way they report polyps. And it's taken us years, and I would say it's only recently that in my hospital we managed to convince the pathologist, and now they're giving us reports like that, because that will determine how you're going to treat this patient. Are you going to put him on long-term steroids or not? I think biologicals, I have only 5 minutes, so I'm just going to just touch on a few points that I felt. I think biologicals in a discussion on allergic rhinitis and nasal polyposis is really not warranted right now. I mean, if you really look at it, yes, touch on it, but biologicals in allergic rhinitis, absolutely no. Haven't heard of it being used. Biologicals in nasal polyposis, biologicals for asthma, yes, but not allergic rhinitis. I mean, I haven't really heard of that being used. You mentioned the indications for biologics, and that's great. But let me tell you, I think I have been practicing rhinology for a good 30 years, and till date, I have only one patient that I have even thought of giving a biological. So I think it's overrated right now, I would say pushed by the pharmacological companies. But if you really look at your practical things, it's not needed as much as it's warranted or it's told. I liked your classification. I think if you look at allergic rhinitis, you mentioned it very well that nasal corticosteroids are your predominant treatment. But again, from a practical perspective, how would you decide what are you going to give to a patient? And what I would do is if my patient is really complaining of sneezing, watery rhinorrhea, watering of the eyes, the treatment would be more towards the antihistaminics. But if the patient complains more of nasal blockage, nasal symptoms, my treatment goes more towards the intranasal corticosteroids. So it's also important because remember that when you give the treatment, you are telling a patient, you're going to need this for the rest of your life. You don't expect the patient to come every time to your clinic, he sneezes. So what do you tell him? This is what I tell him. If you have sneezing, 1, 2, 3, you use this. If you have nasal symptoms, you use this. The other thing to remember is that when you finish, the patient comes back to you, says, I'm absolutely fine, I'm okay. What we have a tendency to do, we say, abhi sab band kar do. Don't ever do that. Intranasal corticosteroids, if you start it for your patient, continue it for at least a month after the patient's symptoms have gone, and then slowly, take it off. That's something you should remember to tell the patient, because then otherwise they'll be back in your clinic after a month saying they have the issues. And what's the first thing I think you should have put in your management was avoidance of allergen. Before we give pharmacotherapy to a patient of allergy, whether it's nasal polyposis, allergic rhinitis, your first counseling to the patient has to be, how would you avoid the allergen? You mentioned house dust mites. You mentioned the patient may have mold, fungus. But what is it that you're going to tell them to avoid? So these things are very important, like changing the bed linen, removing carpets, making sure there's sunlight in the room, making sure that the walls are not damp. These are the more important things than treating them. So I think these are a few points, and of course, I'm open to if any questions are there. sorry, last one. You mentioned posterior nasal neurectomy for allergic rhinitis. It's never done. It's done for vasomotor rhinitis, not for allergic rhinitis. So please, that's not appropriate. Inferior turbinate reduction is not treatment for allergic rhinitis. It's a supportive surgical, part of your surgery that you might do, but it's not treatment. So not to be mentioned for allergic rhinitis. I think that about summarizes a couple of points that I wanted to make. If anything
Ma'am,
else, I'm willing to discuss.
you have 10 minutes. You can.
Oh,
you
okay,
can-
okay. Then I thought I had only 5 minutes,
You
so
have
I
10
took it
minutes.
there. Any other things that people have in terms of questions? I can take them on if there is.
I think I request Dr. Kipamai and Dr. Akriba, can you take the questions?
Nice presentation by Deepshika and many things.
I think I can
Kipamai,
read a question. Yeah.
Your
Hear me? Can you hear me?
volume. Kipamai, you increase your volume?
Yeah, can you hear me?
Yes, yes. I
It
can
was a
hear.
nice presentation by Deepshika. I congratulate her.
Thank you, sir.
And there are many questions there in the chat box.
I can't hear him.
Okay.
Shall I
Akriba,
do the question?
yeah, Akriba, can you take?
Yeah,
His
yeah.
voice is-
Congratulations, Dr. Deepshika. It's with a very nice presentation. So there's a question by Dr. S.B. Fukan, sir. He asks that how Denny Morgan sign occurs. That's a question he has asked. So
The
can
Denny
you-
Morgan signs mainly occurs, I think, because of repeated swelling. There will be a creasing around the lower eyelid, which will cause skin thickening or loss of the skin elasticity occurs there, which might result in the Denny Morgan line. Though the exact mechanism is not fully understood, but they have been linked to the chronic inflammatory thickening of the skin below the eye.
Okay, so
Thanks, sir.
sir has given another question. What is London-Mackay system? I think that is CT scoring, which you have already mentioned, I think, in your
Yeah.
slide.
Yeah, and
So you
that scoring system actually is for chronic rhinosinusitis. It's not really for nasal polypus. The original Lund and Mackay was for CRS. Am I right, Dipshika?
Yes, ma'am. It is for CRS, ma'am.
Okay. Then there's another question by Fukan sir. What is T helper 17?
T helper 17 is mainly, it amplifies the inflammation in the allergic rhinitis that adds to the Th2 response as much as I.
So T helper 17 is the one that produces the interleukin 17, and it's one of the ones that we look at nowadays as a phenotype for the T3 type. It's more associated actually with autoimmune diseases. So it's not only allergic, but it's how it changes the entire immunological response of a body. It's more seen in autoimmune diseases.
Then the next question is mechanism of AERD by Fukan sir.
ARD, it mainly it decreases the PGE2 secretions, and that
Basically, there's a defect in arachidonic acid metabolism, in ARD.
and increase. I think it increases the leukotrienes. Leukotrienes and causes asthma and nasal
Systemic leukotriene.
systemic
So
inflammations.
it's actually aspirin exacerbated respiratory disease for those of us who maybe don't know what AERD is. It's actually what happens on a pathophysiology thing is the cyclooxygenase pathway shifts to what we call a lipooxygenase pathway. That's what happens at a very cellular level. And that shift is what causes the production of leukotrienes. It's important because when we look at asthma patients, especially about 2.5% of asthma patients will have AERD. And 15% of these patients will end up coming to you in casualty with very, very severe asthma. So that's why it's important. From us point of view, from ENT surgeons point of view, about 10% of our patients who have chronic rhinosinusitis with nasal polyps will come to us with AERD. So if you have a patient who has chronic, rhinosinusitis with nasal polyps, always ask history of aspirin sensitivity, and also if they have associated asthma. That's another thing that I think I forgot to mention, but if you have patients with allergic rhinitis, again, when you counsel them, when you talk to them, you've got to tell them that 40% of these patients are going to land up with asthma. So very important to keep counseling the patients that, if your child gets breathless, or if you get breathless, if you get cough, which is not responding to normal treatment, there is something else that we kind of need to also look into.
Okay, the next question is, what is anti-TSLP biologic?
I don't know this.
It's tezepelumab, I guess. So even I don't know much about it. So what are the side effects of intranasal corticosteroids?
Deepshika, you want to take this?
Yes, ma'am. Ma'am, the side effects are mainly it can cause a thinning of the blood vessels in the nose, in the nasal mucosa, which might lead to epistaxis. There can be nasal dryness and irritation, burning sensation of the nose. Other things, ma'am.
Yeah,
If
it's great. So
could
I
have
would just divide them into local and systemic. I think the systemics are overrated. There was a long, I think, a couple of studies that got published some time back where they said that INS-CS caused over a long time causes glaucoma. And this has been totally now removed. We have recent literature which says this is false. So again, you have to speak to your ophthalmic colleagues and tell them that doesn't happen. As far as the local effects of INCS is concerned, and I'm sorry for using the short form, is because we do not take the time to tell our patients how to use the intranasal spray. If you teach them the right technique to use the intranasal spray, which is to direct the bottle always laterally, the chances of that drug hitting the septum and thereby causing epistaxis and dryness definitely reduces. So I think it's not just the problem of the drug itself, it's how we ask the patient to use it. But yes, long term, there were reports of it causing effects with growth hormone. There were effects of it, on the orbit. But right now, I think literature says these are overrated. It's not so much.
So the next question is, like, when you have a patient with allergic rhinitis, when will you tell the child has asthma? So maybe his sir is pointing to the unified airway disease concept. So when
Deepshika?
Actually, before we used to think that allergic rhinitis is only a disease of the upper airway, but now it has been seen that actually allergic rhinitis includes both, means the upper and the lower airway also. So this is what causes so the inflammation which occurs in the upper airway, that also being done in the lower airway, and because of the release of the interleukins and the cytokines, I think that results in the lower airway diseases like bronchial asthma as much.
I think to answer that question, I'm not going to tell the kid he has asthma. I'm going to ask the pediatrician to tell the kid he has asthma. It's not something that me as an ENT would be telling. Remember that the word asthma carries a lot of fear in a parent's mind. So for me, if I have a child who has history of allergic rhinitis, coming to me repeatedly with cough, I'm going to introduce the fact that, look, as Deepshika rightfully said, this is a united airway and things are now going down to the lungs. But I am going to take the help of my pediatrician to also look into the child's chest. I will always, of course, always look at it. If the child has a wheeze, if the child is coming back to me repeatedly with attacks of cough, I'm seeing the child needing inhalers. So, either nebulizing or inhalers. That's when I start telling the parent that this is now something beyond just the nose. We will use the help of a pediatrician. And I rarely use the word asthma now. I do tell them things like, I use it like, allergic bronchitis, because I think for them, the word asthma is very scary. So for me to tell a child that they have asthma, I'm going to have a pediatrician work with me before I do this.
Thank you, ma'am. So the next question is, to deal with neutrophilic polyposis, does EPOS 2020 help? That's a question.
It does. EPOS has now changed it. They have, I think, upgraded their guidelines as of last year. But yes, that's exactly what I went by saying phenotyping, because if I have a polyp report which is predominantly neutrophil, this patient is not going to be on steroids for a very long time. This patient is going to be shifted to an antibiotic, preferably macrolides or doxycycline, and that's something that I'll give for a longer period of time.
The next question is by Dr. Prasoon. He has asked, what is the take on steroid and xylometazoline in combinations? So we see the combinations nowadays in the market. So
no, I won't use combinations. I'm worried about the xylometazoline. Whatever said and done before you and I know it, the addiction does come in. There's no question about it. For me, the use of xylometazoline really in practice is only in acute sinusitis, when I really want the decongestion, or immediately post-operatively. But other than that, I think, again, counseling the patient that, look, when we are putting you on intranasal corticosteroids, it's going to take a couple of weeks to have an effect. And when you talk to them about xylometazoline and its probable addictions, and I have children who actually ask their parents, drops dalo naak mein. So that's something that if you counsel parents, they do understand. So I personally would not use it.
So next question is by Dr. Pradeep Sakya. So for how long does one use how long is it advisable to use nasal corticosteroids?
Dipshika, you're the authority on this. Come on.
Minimum we can use it for 2 to 4 weeks to assess a response. After that, if long term, then we can continue it for 3 to 4 months, or during the season or throughout the exposure period we can continue. And slowly, if the patient symptoms stops, then we can slowly taper, and we can slowly stop it, but not abruptly, as you have mentioned before.
I will give it for as long as the patient has symptoms. There's never, I never tell a patient you're going to use it only for this month or 2 months. It's all going to be a combination of what the patient is telling me in history. Am I getting, like I said, the first management is not the nasal corticosteroid. The first line of management in any patient of allergy is avoidance of allergen. That's your first one. You have to first counsel them about that and then come down to this. Believe me, if they do the avoidance of allergen, the use of the drug will go down. You will identify what is it that triggers it off. If it's something that's triggering off in a season, then I'm going to tell them, okay, use it for that season. So there's never a general thing about you use it for 2 weeks or you use it for 4 weeks. It has to be customized to when does the person have a problem? How long does he have a problem? What is the irritant? For example, if I have a patient who says every time I go to an X area, I get the problem. I'm going to tell him, okay, you're going into that area, use this, the intranasal steroid before that. So it has to be customized to that. I don't think there are any generalized things about how long you can use it.
So the next question is by Dr. Bhaswati. So she has asked, in a patient of allergic rhinitis, do you give a conservative management first, or do you do a skin prick test first?
We actually, I think we should go for start with conservative management, and then because the patient is presenting with us with symptoms, so to relieve the symptoms, and after that, we can go for the skin prick test after taking the required precautions for that.
So my answer to that question would be, what are you promising the patient by doing the skin prick test? Because what the skin prick test does is, it does not tell you that you're allergic to something. The skin prick test tells you that you are sensitized to a particular allergen. It is not telling you you're allergic to it. The allergy is something that you will pick up with clinical history. So if it's a question of, am I promising the parent, ki, okay, we'll do the skin prick test and I'm going to tell you avoid 8 things in your life out of a lot of things that the kid does, and that's going to cure you? No, it's not. So for me, the skin prick test really is not something I would use in allergic rhinitis. I might use skin prick test more for things like asthma, but not for allergic rhinitis. It would always be conservative management first, and only later on maybe I would maybe think of an SPT. But again, as of now, never referred a patient for a skin prick test for allergic rhinitis. I've referred patients for skin prick test if I've had patients who are coming back to me repeatedly with nasal polyposis. I don't know what's happening there. I'm not able to determine what is it in the history that they should avoid. So it's a question of what are you achieving with an SPT? Are you doing it for because the parent is asking you for it, or the patient is asking you for it, or is it going to really impact your treatment? Or I would do SPT if I'm now starting to think of giving this patient immunotherapy. Then I need SPT. So you have to look at why you're giving it, or why you're getting it done. Sorry.
The next question is, how many days or months would you give macrolides?
So there are no specific guidelines for this. Dipshika, do you have any latest guidelines for macrolides?
No, ma'am.
Yeah, so I think from what we've read up from the Japanese literature, they've given it to patients for 3 to 6 months. I think I would give it for a minimum, 3 months is what I would tell the patient, and then look at how the patient is doing symptomatology. If the patient's symptoms have all gone, I would stop. But macrolides up to 3 months, absolutely okay.
Ma'am, may I ask what is the dose you prefer, macrolide?
I use roxithromycin, 300 milligrams once a day, and we give it for about 3 months. Though the Japanese use it in a much, much higher dose. That's where major literature has come from.
You can go for clarithromycin too.
You can. I just use roxithromycin. You can use any of the macrolides, and of course doxycycline. That's the other one that you can use.
Okay. Thank you, ma'am.
But madam, one thing I have to clear. Actually, for neutrophilic, it is the macrolide. For your eosinophilic, it is the doxycycline.
No, sir. For eosinophilic, it will be steroids. It'll
Please
be
stress it too, but this is written in the OCNA book that this doxycycline and the steroid, INCS.
I wouldn't, sir. If I have a histopathology report that gives me eosinophilic, then it's going to be mainly local steroids. It's going to be more of steroid and nasal douching, etc. If I get a neutrophilic, then I would give macrolides or doxycycline.
One thing, just you have mentioned, I asked a question about the childhood asthma. How to tell the parents? It's very difficult. If the parents, particularly the mother, asks whether my child is developing asthma, I tell them, if you have got asthma, if the family is positive, you can take some. I have discussed with this with the pediatrician also in the IAP forum. They told that you have to tell that if the family is positive and mother is taking INCS and inhaler, and see, then you can tell that you are also going to that line. Or it's a bronchial hyperresponsiveness, BHR.
Sir, there's a asthma predictive index actually.
It is there, yes.
Yes, so you can look up to that and maybe predict and then refer to a pediatrician if you think it's highly.
That was discussed, yes, correct.
Yeah, yes. So the next question is by Dr. Orina. How long should the nasal douching go on?
It can go on for weeks to months, and it is safe for long-term use also. I think so.
I tell my patients, you brush your teeth every day, don't you? And you brush your teeth because you don't want to see a dentist. So if you don't want to see me and you don't want to pay money to see me, do nasal douching every day. And if they make it a habit, it really, really reduces their reliance on needing allopathy. So I generally tell my allergy patients, if you just make it a habit, it takes like a couple of minutes, do it every day. It's not doing you any harm.
Dr. Arena, I didn't understand this question. So any particular combination? I didn't.
Yeah, so I think she's asking in terms of what
Water.
is it that you would advise them to douche with?
Okay, okay. With the hypertonic or
Yeah,
isotonic?
yeah. I think it would be mainly isotonic. Hypertonic would not be advisable unless it's in the immediate post-op period because it does cause a lot of irritation. I think it's again how you put it. I usually tell them if it's too much of a trouble to buy, the particular salts that are commercially available, a pinch of table salt, a pinch of baking soda, that's good enough. And add it to about a glass of water. That's what I tell them is the easiest way to do it. So I think that answers that.
Okay. So, ma'am, there's another question. Dr. BJ, does saline nasal spray have sufficient role to play so as to reduce usage of intranasal corticosteroids?
Dipshika, you have to take the question first, always.
Oh, ma'am. Achha, ma'am. Actually, this saline nasal spray helps in douching by clearing the mucus and the allergens, and that reduces the nasal congestions and improves the mucociliary function, and in thus this helps.
Yeah, so I agree with what Dipshika is saying. If you look at why you're douching, you're really douching because you want to do good mucociliary clearance. I feel saline nasal sprays don't make so much of a difference to the mucociliary function. I think they act more as a lubricant. I sometimes feel they act more for us to feel that, oh, yes, we are doing something. But between the two, I would any day prefer nasal douching to saline nasal spray. There are some patients who are very unhappy with douching. They say, oh, when I use it, I get a headache. I feel too much water goes into my throat. So those patients in whom the compliance would be less with nasal douching, maybe you would give them a saline nasal spray.
Okay. By Dr. Nikhil, do you use budesonide in nasal douching?
Budesonide provides when we add to saline nasal douching, it actually provides both mechanical and I think local anti-inflammatory action. So that clears the mucus more, and also I think so.
No, I wouldn't use it routinely. I would use budesonide only in a patient who I have documented allergic. So eosinophilic, for example, your CRSV with and nasal polyps with an eosinophilic proponent in the histopathology is the person I would use a budesonide for. Otherwise, I would generally prefer normal nasal douching. So unless I have really a history of the strong allergic component, I wouldn't use budesonide. The only other patients where I really use budesonide and nasal douching are the patients of allergic fungal rhinosinusitis. They post-operatively are already always given this. So I think that instead of budesonide, sometimes that becomes a little challenging because you ask these patients to buy the respule of budesonide or the little ampule and they've got to break it into the nasal solution. You can even get the ophthalmic solution. You get the ophthalmic prednisolone drops, and you can even ask them to add a couple of those drops into the nasal solution. That also works very well.
The next question by Dr. Anjan. So he has asked why ready-made steroid nasal douching solutions are still not available.
Because of the systemic side effects, probably, and it lacks the standard dosing. So
I think there may be an issue with biocompatibility. I'm not sure whether steroid kept over a long period of time. I mean, I think it's that. But I think for this question, Dr. Bhuyan, I can assure you both Dipshika and me right now don't have any interest in getting into a pharmaceutical production. So can't really answer this.
But it is in inhaler, we put budesonide in inhaler, but not in INCS. Not in INCS, as Anjan has asked, why not in INCS like the inhaler?
Yes, yes.
You have the steroid
That's
in
what
the
I'm asking.
INCS.
Mhm.
No, for inhaler, budesonide is there. formoterol or your salmeterol with budesonide. But for INCS, budesonide is not available.
Yeah, I don't see this. I think part of it may be that there's not so much of a market for it. I think that's the way I would look at it. Not very many of us also use budesonide nasal douching that commonly. So I think from the pharmaceutical point of view, I think the requirement or the need from us hasn't gone to them. If we start telling them we need this, I'm sure they'd think about it.
I
So I
think this
think
ends our questions.
Yes, yes.
We can end. It is already 8:05. So this is a very
9.
nice discussion. So last is vote of thanks. Respected chairpersons, esteemed experts, moderators, dear members and participants, we are sincerely thankful to our speaker, Dr. Deepshika Bhattacharya, for her insightful and well-structured presentation on allergic rhinitis and nasal polyposis. Our special thanks to our expert, Dr. Neelam Vedman. Thank you very much, madam. Your great this discussion. It was very valuable perspective and enriched session. Very good discussion. We also express our appreciation to our moderators, Dr. Kipama and Dr. Akriba Ahmed, for conducting the session so smoothly and sharing their valuable inputs. A big thanks to all NEBOI members and postgraduate students and other, I think, madams, some residents has joined. Thank you all for joining, for your active participation and continued enthusiasm for the academic learning. Thank you all once again. We look forward to your continued support in future sessions. Have a great evening. Thank you, everyone.
Thank you. Thank you.
Thank you, madam.